Hello, and welcome to today's COVID-19 presentation on addressing the pandemic in rural communities. I'm Caroline Gumpenberger, Director of Education with the National Healthcare for the Homeless Council, and I'm the moderator for this presentation. Our format for today's hour is a coffee chat. We call them coffee chats because they are informal conversations. We invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for all of us to share ideas, challenges, and support for one another. We hope that you'll engage throughout the session. One of the best parts of a coffee chat is getting to hear from people doing similar work all across the country. So some instructions about how you can engage during the chat today. We want to hear from you, and we encourage your questions and stories throughout the presentation. The more you all engage, the better this chat will be. You can type directly into the attendee chat pod to the right of the slides. Your comments will show up to all participants, and I will refer comments and questions to the panelists as they come in. If you like, please feel free to go ahead and say hi in the chat and let us know where you're from. Before I introduce today's panelists, I do want to point out some of the COVID-19 resources that we have available. We have the COVID-19 resources link in the resources pod. You can click that link to find all kinds of COVID-19 guidance specific to homelessness created by the National Healthcare for the Homeless Council and other partners. Also in the resources pod are links to registration pages for upcoming council coffee chats and webinars. Additionally, outreach materials that will be discussed today are available as downloadable files in the files pod. And now I'm very happy to introduce to you our panelists today. They are Melanie Cordell, CEO at the Tennessee Valley Coalition for the Homeless in Clinton, Tennessee, Cindy Manginelli, Tenn Care Shelter Enrollment Project Coordinator at the National Healthcare for the Homeless Council, and Netta Linder, Program Development Manager at Partnership Health Center in Missoula, Montana. Welcome, and I'm going to invite each of you to tell us a little bit more about yourselves. Melanie, how about we start with you?
Great, welcome. I am so glad to hear about this presentation, about us talking about rural communities, and I'm looking forward to a very enlightening discussion with you all. I have been the Chief Executive Officer of the Tennessee Valley Coalition for the Homeless for about 10 years. I started in nonprofit work in 2002 as the Director of a domestic violence shelter. I have lived in a rural community all of my life, and I am now overseeing 12 rural communities in East Tennessee. So I look forward to this discussion. Something personal about me, I have two children, two girls, ages almost 16 and 12. And I am from a small town next to Mexico City in Florida. That's where I was born and raised.
Great. Thanks so much, Melanie. Cindy?
Yes, as Caroline said, I'm with the National Healthcare for the Homeless Council, and I'm a project coordinator there. And a big part of my job is connecting with all kinds of programs that provide direct services to the homeless and ensuring that the clients that they work with are able to enroll in Tenn Care or able to find health care if they're not eligible for Tenn Care. And we also do a lot of trainings on homelessness and health care related issues across the state and sometimes on a national level as well. Specific to the COVID-19 crisis, we've been working with continuums of care as well as individual programs to really figure out in these rural areas and also in more urban areas here in Tennessee, what can we do to help those who may be sick, to help those who may be scared, and done a variety of things with very small individual projects and then, like I said, with COCs as well. I am also calling from my home today where I have 3 teenage children and 3 dogs. So I told everyone before the call, I set out a bunch of dog bones and a whole lot of manicotti, and I'm hoping that everyone will be quiet so that we can cooperate. But I'm really looking forward to the discussion today as well.
Great. Thank you, Cindy. Netta?
Hi, and I'm Netta Linder. I'm a Program Development Manager at Partnership Health Center in Missoula, Montana. I've been working at Partnership for the last 10 years. In my prior life, I was a 911 emergency dispatcher and worked under the Office of Emergency Management under 2 different counties, one where I'm originally from, which is one of the most remote areas in the lower 48 states by a lot of measures. That's way up in northeastern Montana. I describe it as almost North Dakota, almost Canada. And culturally, it's a bit of a mix. and I moved way over to the other side of the state in Missoula, and I've been at the clinic for most of the time here in Missoula. I have been working with the healthcare for the homeless population in some capacity during the last 10 plus years at the clinic, and during that time I've also been an active member as a representative of the clinic for the At-Risk Housing Coalition, which we'll be discussing a little bit more about today. There's a large coalition of our community partners that have really been active in working with us on the COVID-19 issues.
Great. Thank you all so much. So now we'll move on to the discussion questions, and the panelists will respond. We encourage you, the attendees, to respond as well. Please type your responses or questions into the chat pod as you've been doing. All right, so the first question is, how have you been conducting outreach and education in your community? And have you experienced any barriers, such as mistrust of the government, media, or the healthcare system? And what outreach strategies have you found to be the most effective? Netta, how about we start with you?
Okay, gladly. So we have quite a few folks through our At-Risk Housing Coalition who conduct outreach, and sometimes we're able to supply a doctor if we have one that volunteers to go with folks. But really our coordinated outreach team consists of folks from a number of agencies, and a lot of that are places like Open Aid Alliance and Homeless Shelter, our large emergency shelter, the Poverello Center, and from the Hope Rescue Mission, which is a faith-based facility, and Missoula Interfaith Collaborative. So they have folks that go out and have been going out for years and build rapport with a lot of our folks that do what's referred to as rough sleeping. So those are the folks that typically sleep unsheltered. They might be the folks sleeping in doorways, culverts, over train trestles, out under freeway bridges, or that sort of thing, or in tents. But there typically are folks that are unsheltered, and they tend to be in a couple of very distinct areas. If they're not folks that go way up out in the mountains just to get away from folks. And because we have so many folks that go out, we have a lot of volunteers that go out with coordinators on the coordinated outreach team. What we did for COVID-19 is we got attached to the county health department incident management structure under one of what's called a COAD, the Community Organizations Active in Disasters, and they assigned a point person from the county to kind of oversee some of the meetings that were going on, and that broke out into a lot of different task forces, which is where a lot of these materials that I'm going to review quickly came from. So they put the materials together. You can see that we've got some education information on this first flyer about what to do if you're experiencing symptoms, how to take care of yourself, how to do in terms of protecting yourself and others from possible spread. We did use pretty conservative measures on that. And then if someone's sleeping outside, some instructions on avoiding large groups, et cetera, and sharing things that might have saliva transfer, because we know now that it's droplet spread. And then they have quite a few links. Some of our folks are pretty tech savvy that are experiencing homelessness or at risk, and they have phone numbers. So they were able to post some of this information that I'm going to share on stakes in some of those more common areas, and I believe folks distributed some leaflets. We did have members out of the COAD who stepped up to develop the materials, and other members who vetted the materials through FEMA and through the health department to make sure that the information was current with the Center for Disease Control guidelines, and ran them through for FEMA approval, I believe, and then someone allocated funding out of one of their offices to print these. So we do have Another thing that we have is just instructions on what should I do if I feel sick, and we provide a lot of information. And because we know, especially in an already highly marginalized population, that's likely experiencing trauma. I know a lot of folks, homelessness in and of itself can be considered a form of trauma when you have no stable base and you're struggling to take care of basic needs pretty frequently. So we do provide mental and behavioral health information. I believe some of the work that came out of one of our other co-ads is the Behavioral Health Urgent Care Clinic. That's listed as the first thing. That was actually converted out of one of our treatment centers in pretty rapid fashion to create more on-demand access for folks who needed urgent mental health care, because we recognize that with the high degree of social distancing and social isolation, plus all of the uncertainty and fear that were floating around at the beginning, not knowing what to expect. With the virus in itself and really not knowing much about it, that folks were more likely to be experiencing mental health symptoms and likely in need of additional support. And that's across the board beyond the population experiencing homelessness as well. The flyer that's attached to this on the right side of your screen is our court information. We do have, again, a number of groups that are active with the population that has contact with the justice system. And I know I probably don't need to give that overview to most of the folks on this call. It's not uncommon for folks who have lived through trauma and experienced homelessness to have substance use disorder problems or contact with law enforcement. Not to say that that's the cause of it, but people who are experiencing homelessness are more at risk for continued contact with law enforcement and justice involvement throughout their lives, in part just because of exposure and lack of access to shelter. So we do have a number of contacts listed on this as well that were easily available to folks for outreach. And then the last part that we have, because so many services, because places like the Social Security Administration closed its doors, our Office of Public Assistance, the office that oversees our food stamp benefits that we call SNAP, and our Medicaid programs closed their doors. So if you didn't have access to a phone or computer, you couldn't drop in and get assistance with public benefits in a timely manner. And a lot of places, like some of our mental health agencies, didn't have their community-based rehab and support folks or their peer support folks or case management on the ground. A lot of places pulled them. So that was, for some folks in that population, that was their only contact with folks that provided services and basic needs. So a lot of folks pulled together in another, what we called our pro-social group, and that was problem solving and making places to access tech hubs and wireless equipment so that folks could access their basic needs through public support programs. So I believe that's all I have for flyers to walk through.
Great. Thank you so much, Netta. And just as a reminder to our participants, all of the resources that Netta just gave us an overview of are also available in the Files pod as downloadable files. So please feel free to grab them there. I know some of them were a little bit hard to see in the slides, but feel free to grab some and use them as examples if you'd like to. And now I'd like to ask the same question to Melanie and Cindy. I know you've been working on a lot of this together, but just as a reminder, the question is, how have you been conducting outreach and education? And have you experienced any barriers such as mistrust of the government, media, or the healthcare system? And what strategies have you found to be the most effective?
This is Melanie. I'll go ahead and start. Cindy, tag team anytime that you're ready. I think that we really began looking at COVID in a homelessness capacity back in early March, and we really decided, okay, we've got to get with our stakeholders and figure out what are going to be the best ways to reach out to the homeless population before it becomes an epidemic within our local communities. So what we decided to do is have weekly phone calls with certain stakeholders that represented different program types, such as emergency shelters, transitional housing, permanent supportive housing. We also have a domestic violence representative, the VA, HUD, and a housing development agency that works through the state. So we started having these weekly phone calls and decided that we did not have many individuals that tested positive for COVID. And we only had about 10 individuals that were symptomatic for COVID. So we decided that we felt like we needed to go to the community, to encampments, abandoned buildings, the Walmart parking lot, and just start beginning to talk to individuals on the importance of staying safe, the importance of isolating in place, what to do if they have symptoms, and can they get to a local health department or emergency room. And we also decided to create hand washing stations for each of the encampments that we came up with, and also hotspots in some of the communities. We began this a 6-week strategic initiative, really focusing on the counties that had the highest positive cases of COVID. So we started with the first 6 counties, and again, we cover 12. And we have a development director, her name is Mikkel, who has created a YouTube video with Cindy with the National Healthcare for the Homeless Council. And Cindy goes through and really discusses how to conduct outreach and provide education to the homeless population in rural communities. And with this YouTube video, we are training volunteers that's in the local communities to conduct street outreach with specific stakeholders that is in their communities. So it's working very well with those volunteers to be able to rely on current mental health agencies. If you have an emergency shelter in that community, they're a part of this street outreach. And we look at where those hotspots are, and the teams divide up and go and meet with those local individuals that are currently experiencing homelessness. It has provided very fruitful. We have had individuals that have been symptomatic and have also had no symptoms, and so we're able just to provide flyers and educational materials to individuals that are experiencing homelessness and really be able to educate them on what is going on in their local communities, where to go to be able to get tested, if they are offering free testing or not in those communities, and really it's just a better way to access that. As far as social media, every single day we are posting on social media through Facebook, Instagram, to let the homeless population know that we are here. We know that they may be scared during this time, and giving them the resources that they need to be able to access their healthcare communities in their local community. As far as mistrust of the government, I don't really think that COVID has had a big play in that mistrust. I think a lot of the individuals that are experiencing homelessness just mistrust the local government, the local sheriff's department, and now that COVID has come into play, they really want to be able to be seen as a human being that is experiencing symptoms instead of, always showing a distrust to those individuals. So we really are just treating everyone like we would want to be treated. We want to make for sure that when they go to the local health department that we are there to be with them along in this journey. We can't be with everyone, and we do not provide transportation for everyone. And we'll talk about transportation a little bit later in this chat. But I think it's really important that we all just remember when we're training our local communities and stakeholders that these are individuals that's scared just like everyone else is, and that we all need to work together to make for sure that everyone gets tested if they need it.
Yeah, this is Cindy. I would just add to what Melanie said that we really can't overemphasize the role of mistrust. And I think very well said that mistrust is always an issue, and I find to be a very profound issue specifically in rural counties, where sometimes even among people who are housed, there's a general mistrust of the government, and specifically around health care. You know, many rural counties, hospitals have opened and then closed and then opened, and groups have come in and done projects and then disappeared. And I think in general, when I'm in rural counties, I find that people very often want nothing to do with health care. And this may just have compounded that. Here in Nashville last week, we had someone who was experiencing homelessness who left quarantine and was arrested and charged with fleeing a penal institution, and that was spread all over the state, that story. And so obviously that creates a lot of fear. Am I going to, if I go in and I get tested and I'm positive, am I going to lose all my freedom? Am I going to be incarcerated? Am I going to be separated from those that I love? And unfortunately, especially maybe in rural counties, we can't even answer those questions. Sometimes we don't know what's going to happen. And so that has increased that mistrust. And then also when we look at people experiencing homelessness who are relying heavily upon case managers and support groups and behavioral health agencies, even those that had established really good support systems, for most of them, those support systems have disappeared during this time. And so case managers who were always accessible, who met with me every week, suddenly don't answer, and they're not in the office. That support group that I went to every week, I'm not welcome in the building anymore. Or I go to the building and they're handing me a mask to put on. And so even those that were deeply trusted, suddenly now those relationships are compromised. And I think as we go forward in this kind of work, all of us are going to have to be aware of that. We're going to have to realize that long-established relationships may now be jeopardized. And what are we going to do about that? How are we really, for many of us, going to start all over in reestablishing trust? And so street outreach is certainly part of that, but I think we're going to have to keep that in mind as we go out too. And what's made street outreach a little bit more complicated, specifically around the topic of COVID, is that some of the people that we're reaching out to are afraid of us. You know, I've talked to many counties who've said that they're not welcome in camps, that they're not welcome because people are afraid that the virus is being brought to them by street outreach workers. And so that's something we have to be really cautious about too. We can develop really strong programs, and we've all worked really hard to do that. But if everyone's afraid of our program or no one trusts us, then it's all in vain. So as all the work that we do in this field, we've always got to have that relational piece in mind and figure out how are we going to specifically address the relational issues and the trust issues that have been created as a result of this pandemic. I think we're all feeling that. You know, it's hard to go to the grocery store and know, does this person scared of me? Am I walking too close to them? People that we're reaching out to are experiencing those same fears and uncertainties, and that's really important to keep in mind.
And this is Netta again, and if I may add to that, and one of the things about maintaining and building trust, because that's been a huge issue I've had to explain to folks over the years, that we're not microchipping folks by administering vaccines, et cetera. And I know that's kind of an extreme example in some cases, but is that just on the local level for your case managers, for your street outreach, for any of your staff, do what you say and say what you do. Follow up, be consistent. Don't give them a reason to believe that you're not going to follow up and be there with what you said you were going to. Do not overpromise resources. It is so critical. And it might be something as simple as saying that you'll meet someone outreach-wise on a Tuesday, and then if you don't make it or if your outreach time isn't available and someone was counting on that, that can be devastating. So one of the things that we've done for rapport building in the past is some of the outreach teams from the shelter or from other programs. Like the clinic has put together maybe some simple wound care supplies in a bag with contact information for folks, or an information flyer, and they've given that out to help people treat blisters or something like that. just having something small but tangible to offer can really help.
Great. Thank you all so much. And I think that that's really a great lead into our next question, too, which is how responsive has your local public health authority or your local emergency response teams, how responsive have they been to help identify solutions for people experiencing homelessness? Or do you feel that you've been left on your own to figure it out? Melanie, do you want to start with that one?
Yes, absolutely. Our local health department, as well as our state health department, have been instrumental in trying to provide resources and assistance to the homeless population. I'll give you an example. I received an email and then a follow-up phone call from the state health department asking for our continuum of care to assist a female individual who had tested positive for COVID, and this was back in March when all of this just came out and we were just beginning our planning. And she said she's at a local halfway house and is experiencing homelessness, and she's going to have to be isolated and quarantined in a motel somewhere. So we had to identify a motel that we knew that FEMA would help reimburse with, and so that took a little bit of time to be able to do that for this individual on a Friday night. But what was so cool about this opportunity is that not only were we able to work with the state Department of Health, but we also worked with the regional health department, and they helped provide transportation or navigate transportation for the individual that needed to be quarantined. The shelter decided to transport the individual since the individual had already been there at their shelter, and we met her that night and provided some food and some gift cards for the individual to be able to access smoking and cigarettes and things like that. She didn't have a mask on when we met with her. She didn't have any gloves on, and so we provided those resources for her. Since then, she stayed in the motel for 14 days, and we did have to navigate, how to get food. Definitely wear your mask at all times because you are in a public place where there are other individuals are staying. And then after she was discharged and went back to the halfway house, we began working with the local health departments in all 12 counties that we cover to see what the protocols are in place for their local communities. And then we began communicating externally to the homeless population as well as the community at large how to get resources, how to get masks, where free testing is available. And every health department has been just a breath of fresh air to be able to work with vulnerable populations. Not only are we looking at people that are living outside on the streets, but we're also looking at people that are precariously housed and that are doubled, tripled up in one home. And so we really wanted to be able to reach out to those individuals as well. And so we've been able to get flyers, masks, we've purchased cleaning supplies, and now we are a part of a Tennessee task force on homelessness to work with the local health department and the governor's level, the state level, to be able to provide the resources needed to people in rural communities.
Great, thank you, Melanie. Cindy or Netta, do you have anything to add?
I don't. I mean, in the different COCs that we've worked with, I think initially there was a lot of confusion about what is going to be the role of the health department and what is going to be the role of the continuum of care. And so there was definitely initially some difficult conversations that had to take place. As the situation that Melanie described, I think sometimes it was the crisis of we've got these two people that are positive, and so who's going to do what? I think there was a lot of kind of a dance back and forth in a lot of rural counties of is this, is the local homeless shelter going to take care of this? Is the health department going to take care of this? But I think in a lot of counties they've been able to negotiate that, and as long as they were very intentional and be able to set boundaries and say, okay, this is what we can do and what we can't do, and identify that very clearly, that they've been able to work together. But that a lot of that came out of crisis. That's one good thing that I think is going to come out of this, is that in some rural places, the health department and the local COC, the health department and the local homeless shelter are really talking for the first time, and having to partner together for the first time, and are really forced to collaborate. And while that was always ideal, and maybe there were individual cases where there was more communication than others, now they're having to work on a big project together. And we're really hopeful that that's something that's going to continue beyond the COVID-19 pandemic, is these relationships will continue, and that there'll be stronger partnerships between shelters and health departments as a result.
And I would just echo that sentiment. I know locally there was a little confusion because Partnership Health Center is a subdivision of our local health department, and we are the ones that provide the health care for the homeless direct services. So I think there was a discussion at some point. The sentiment was put forth that, well, homelessness is always a crisis, so why do we need to combine this into the COAD? And fortunately, someone was able to make the case that if we have folks that are displaced from the shelter because they've had to do some distancing at our shelter, typically we have reduced capacity at one of our main shelters, so that displaced about 50 people to 80 people potentially, who then had to go and sleep outside because of distancing measures and capacity. We couldn't have them sleeping so close together, unfortunately. So I think the county saw some value in responding to that. The other thing was, with a lot of businesses closed, because our governor kind of issued a pretty conservative directive in terms of facility closure and business closures early on in March. So a lot of folks didn't have a place to go during the day where they typically would, so they were just kind of out in the public. Potentially, if someone was asymptomatic, may have been exposing folks as they were roaming around town trying to resituate themselves. I think they were able to see the value in it later, and it was nice to have a more active voice at the table from the county health department rather than just from one of our case managers through the program. But I think they've kind of warmed up to it, and they were really instrumental in helping screen and vet for getting quarantine and isolation procedures set up, working with the clinic and other community partners on doing our transportation, figuring out a protocol and a process for that, as well as figuring out sites for quarantine and isolation and a non-congregate shelter. So the city of Missoula did purchase a hotel that has dedicated space for quarantine and isolation spots should we have an uptick. And we're anticipating that maybe there will be an uptick of positive cases. Typically we've had, I think, 38 total that we've had to house since March in quarantine and isolation sites. And we're anticipating that maybe come fall there is possibly going to be another large uptick. So we did have some time to prepare, and someone was able to leverage with the city to purchase the hotel as a quarantine and isolation site in partnership with operating with the county, and to look at FEMA funds for the quarantine and isolation and look at other funds to do a non-congregate shelter. So that's just they're looking at prioritization policy for that too, using possibly our coordinated entry system. If anyone's not really familiar with that, feel free to ask more about that. We've got plenty of resources. Basically, it's our centralized intake, electronic intake warehouse for folks who are applying for housing assistance programs, who are literally experiencing homelessness. And that's what we're looking at doing with the site, and I think there's some temporary funds in place through next year for that. So that should help kind of reduce the demand on our larger congregate shelter. And I believe that the county will be hiring a medical social worker to work with the folks at that site to help them get placed into housing from the non-congregate shelter or the quarantine and isolation spot, kind of help with case management and support services. And I believe that was funded through some of our community access funds that are available through local government. So that's all been really crucial, and it's great to have a high level of collaboration. It wouldn't have happened without that. And I know we've still, as a community, got a lot of details to work out, but we also do have a lot of people power. We have a lot of human capital at the table, so I'm confident that we'll be able to figure something out. And if we don't get it right the first time, we can just try again.
Thank you so much, Netta. And I do want to follow up on those points that you made about transportation and some of the information that you gave us about your isolation and quarantine sites. Thank you so much for that. But first, I want to ask a little bit more about COVID testing and what you said about expecting an uptick a little bit later. Along those lines, what are your COVID-19 testing protocols, and how have you been doing patient follow-up? Have you experienced any challenges following up with patients? And also, some of our registrants also asked some questions when they were registering for this webinar about whether the infection rate is lower among people experiencing homelessness or whether the COVID-19 pandemic is expected to hit rural areas later.
Hi, this is Netta again. So I can chime in a little bit on that. I don't know personally that the infection rate is actually lower among people experiencing homelessness, and the reason being, as we discussed earlier, we're well aware that a large chunk of the population, and a large chunk of the population living in rural areas in general, tends to be kind of mistrustful. I believe, as Cindy mentioned earlier, there's a lot of uncertainty with folks and hesitancy to get tested. We did have a lot of rumors circulating from folks that they'd kind of be railroaded off and no one would see them again, and I know that I've definitely seen some information circulating about CDC guidance or Red Cross guidance on non-congregate shelter, quarantine, and isolation. And I think that's been affecting, I think, our overall ability to test folks, especially the folks that are displaced and out rough sleeping in the community. Availability of testing has been another thing, and we do largely have our testing sites. We have several throughout town that are set up. We're not actively doing outreach testing, and I think part of that's the difficulty with supplies, et cetera. I'm not sure if we'll be able to offer that soon, if we could do on-site testing with one of the docs. They've been great going out and really helping reduce some of those fears and hesitancies. And I think one of the things about, I know some folks have probably heard this referred to as Schrodinger's virus in rural areas. Because of availability of supplies, our data capture isn't 100%. We don't know who's had it, who hasn't. I know there are antibody tests that are in development, but the accuracy is questionable, so they're not really useful. So in rural areas, that data capture and our accuracy of knowing who actually has been exposed or not isn't really great. I don't know that it's adequate. But one of the advantages that we do have in rural areas is when our population's dispersed already, frankly, we're in a frontier state. I think Montana typically has about 7 people per square mile. We got 1 million people, and our state's bigger than a lot of countries. So I think that's kind of worked to our advantage because we're already naturally socially distanced, or at least physically distanced. I think that kind of has helped slow some transmission since it's largely contact or droplet spread.
Yeah. Oh, I'm sorry, go ahead.
Oh, no, go ahead.
Yeah, this is Cindy. I was just going to agree with what you said here in the rural South. I think it's difficult to measure the spread of infectious disease. I think certainly infectious disease spreads differently in rural areas. Sometimes it can be sort of an all or none, you know, where you'll see that we'll have flu seasons and even just with really bad stomach viruses. where it spreads through an area and either a lot of people get it or no one gets it because everyone uses the same store and the same post office. But I think, just as you said, it's very difficult to measure that. Honestly, if you're in a rural area where it's an hour-and-a-half drive to the hospital and you don't have the money for gas, you're not going to go to the hospital for a cough and a fever. And so in urban areas, I think there's been a lot of emphasis on if I'm sick at all, I'm going to get tested, I'm going to find out if I have COVID-19. And that's not often the mindset of people living in rural communities. I go to the hospital if I think I'm going to die. And if I've got a cough and a fever, I'm not concerned that I'm going to die. And so when you think that most people who get COVID, do not have to be hospitalized and aren't that extremely sick, I think that does affect whether or not those people are going and officially being counted because they're not seeking treatment for those symptoms. So I think that's a big part of, it makes it difficult to know how many people have actually had it and how many people haven't. So I think that would be really difficult to nail down. I also think we have to be careful about, some rural counties now, even just in the last week here in Tennessee, have said we're going to open up testing for everyone and we're really encouraging people to be tested. But we have to be really careful about, and this is true with whatever kind of services we offer. If we offer a service that, that brings a lot of new issues to the surface that we're not able to address. So if we do mass testing in some of these areas and a lot of people are positive who don't have any symptoms, what are we going to do with those people then? Are we going to let them go back to their car and be isolated, or does that mean we now have to find hotel rooms for a whole lot of people who don't even have symptoms? And are those hotel rooms available, and are they available in every county? So, so while testing gives us really firm numbers of how the virus is spreading, it doesn't necessarily, it can obviously make services and life a lot harder in a lot of counties where, okay, now we've got a really solid number of who's positive, but we don't have anywhere to put people, or we're, risking more people being incarcerated, or, all the different complications that we've seen when we force people to go into isolation. So it's just something to consider. But I do think that the spread of infectious disease in general is just harder to regulate in areas where people don't seek out health care.
Thank you, Cindy. And that brings up an interesting point, too. I did want to also ask about isolation and quarantine sites, if they're available in your areas and how they're structured. Netta, you talked a little bit about this a few minutes ago. Thank you for that. And I'm particularly interested in hearing from you, Melanie, and Cindy about this, too. Cindy, you just mentioned some challenges around isolation and quarantine. Can you speak to whether there are any INQ sites in Eastern Tennessee, and how, if so, how they're structured?
Yeah, and some counties are handling that differently. As Melanie said, there are large areas where the state or local people have gotten together and set aside specific hotels. The problems with that, just like Melanie mentioned, is sometimes there'll be a region of several counties and they've designated hotels in 2 counties. And so if someone enters isolation, they have to leave their county, which means they leave their support system. They leave, for many of them, the place they've lived their whole life, and go someplace new where they don't have any resources. And so they don't even have anyone to bring them food or to check on them. And in a lot of those isolation places, the health department is trying to, offer some sort of monitoring. Sometimes, like Melanie said, the health department is looking to the continuum of care to monitor. And if you're in a continuum of care that's managing 10 counties, as many of our rural COCs do, then you can see the complications that would cause. So there are certainly designated isolation sites, but they're not necessarily convenient. And then if you look at people who are on parole, who aren't allowed to leave their county, a lot of people will have, an open case with the Department of Children's Services that means they can't leave their county, or they'll lose, that will affect their custody. And so not everyone can just get up and leave their county and go stay somewhere else for 2 weeks. And then, just like we've seen nationwide, isolation, of course, can cause people's mental illness to be exacerbated. It can actually contribute to mental illness in people who haven't had it. Issues around withdrawal with those with substance abuse disorders, issues around overdose. If you have to leave your county and travel even sometimes maybe a couple of hours to a new place, then all of that is compounded as well. So in most rural counties, we are seeing hotel, motel rooms being used for isolation, but it's causing a lot more complications even than you see in urban areas that are doing that. At least that's been my experience.
And this is Melanie. I just want to speak to the pandemic hitting rural areas later. We are looking at the numbers in all of our counties on a daily basis. And if we compare from March to May, you've got a 2-month spectrum, and our rural communities have increased in numbers over time. Some weeks it's been in the 20s, and then some weeks we've gone all the way up into the 60s. But then we have some rural communities that don't have any positive cases at all. So we're not necessarily focusing on that number now. What we are focusing on is what are we going to do in a couple of months from now when people still have not received employment, specifically among the at-risk population. We are looking at how can we get prevention dollars to this community of individuals to ensure that they do not become homeless. We have done some analysis in East Tennessee, and there is about a 40% chance that we are going to see a 40% increase. Sorry, I said that wrong. We're going to see a 40% increase in people experiencing homelessness in our communities. So we are strategically preparing between now and October of this year to reach out to people that are in extreme poverty, 30% and below area median income. And we are looking at working with the literally homeless population to discuss ways to get them into housing with all of this, all the new resources that are coming out. So I really think it's important for us to think strategically when we are looking at the homeless community and rural communities at large, and where they're going to be going in the next couple of months.
Great, thank you so much. So the next question I want to ask, I want to move over to telehealth quickly, and I'm curious whether any of your sites are currently engaging patients via telehealth, and if so, what challenges and successes has this presented for you?
This is Melanie. I can't speak to that directly. The continuum of care does not provide telehealth, but the doctors within the local communities are all doing telehealth. And starting in June, they're going to be seeing patients again in their facilities. But I would say that the telehealth has been a huge success, especially for your emergency shelters where they have access to transportation. They have access to internet to be able to contact a doctor if possible and utilize the telehealth. It has definitely been something that we would like to see used more prevalently in the future.
This is Cindy. I would say with the rural COCs that we've been in contact with, as Melanie said, in shelters specifically, I think that's been very successful, where there are shelter staff who can make sure there's a strong internet connection and that the client is able to be at the, in the right place at the right time with the tools needed to make an internet call. With the unsheltered community, we've had a lot of reports that it's not been as successful. Of course, in a lot of these rural cities, there's just not a strong, reliable internet connection or even a strong, reliable cell phone connection. And so I think among the unsheltered, that's been a lot harder and has not been quite as successful. But, in shelters, I think many people would like to see that be something that's still highly accessible and something that continues even beyond the pandemic, because it's been, enormously successful and helpful to their clients.
Hi, this is Netta, and we have several service sites, and one of the early shifts that we did is so we have our main clinic is an integrated primary health care clinic, and we have dental and behavioral health as well as primary care. And then we do have an embedded shelter site as well. So I think on the shelter site, for the most part, we had our program RN over assisting shelter staff with screening folks initially, so doing verbal screening and temperature checks, and then referring people over who might have been symptomatic for further testing if needed. And early on, we did kind of have to shut down on contact with folks for the first week or so. It was probably pretty difficult. We did have some folks, we weren't refusing inpatient or in-person appointments later on, If they had no other way to contact folks, we were largely funneling them over to the main clinic, I believe, which is several blocks away from the satellite clinic and the shelter. But we did also have, I think our behavioral health unit was the quickest to get up and running with telehealth. I know we've kind of had some discussions around which platforms are the best to use for that. Equipment's kind of been a challenge. As I know, our behavioral health department is considerably smaller than the number of providers we have. We do have a residency program as well, so we have about 10 staff providers and then about 30 folks in a family medicine residency training program. They spend 3 years with us. So it's 24 at this site. Sorry, the other folks go up north to Kalispell for a few years. So some of the providers were pretty good early adapters in the medical portion, and then dental was a little more challenging to get up and running. We were still seeing dental emergency appointments, but they were taking precautions to reduce droplet spread that did take a lot of movement to get going, because it's really hard for a lot of folks, especially, I would say, folks like our nurses, our RNs, and our MAs. I don't know how many of those folks we've got on today, but I know we expect in general in medicine so much of those folks that they have a pretty strong workflow and regimen, and once they get into a groove of doing things a certain way, that's what works for them, and it's quick, and they can get through appointments really well. And if you change a few things, that's really difficult for them to keep up and adapt, and that can cause a lot of stress with staff too. I think most of our nursing staff and MAs were really great at adapting and thinking of new ways to do stuff as we went forward. We are working on setting up another telehealth site. That's in discussion, I believe. I don't know how far along we are just yet, but setting up a room maybe where a lot of folks can do a warm handoff from a provider, where they've maybe come in to physically see a provider. If they don't have access to internet or cell phones and that sort of thing, if they're able to come into the clinic. It does get more challenging with people in outlying areas, and we did apply for some local funding, grant funding, to try to supply very inexpensive smartphones to folks so that we could have outreach or other staff help folks set up a way to contact people so they can continue social distancing, but they aren't cut off from support services. That's kind of challenging. I know one of the perceptions that we'll likely encounter is like, why are you giving people who are homeless cell phones? Because it's essentially a utility in this day and age to have access to the internet. So many of our services, as we've discussed, have been moved to only online. There are no more face-to-face services in a lot of really critical social support and mainstream benefits offices right now. So looking forward to see what other solutions we can come up with our community partners on making sure our folks have access to critical services.
Great. Thank you all so much. Netta, I have one question particularly for you. This was submitted by one of our registrants, and I think you might be able to provide some insight here. Do you have any solution-based ideas directed towards the State and Tribal Council for Montana Reservations? The submitter noted that most of their people are nomadic.
So I am kind of familiar and originally from a reservation in northeastern Montana. It is one of the most remote areas, and they are definitely not as resource-rich as the corner that I am living in right now. I would suggest possibly finding a way around messaging to go against the cultural attitude against providing someone who's experiencing homelessness access to a resource like a cell phone and maybe some minutes, a plan, or a place where they can plug in and charge it and use Wi-Fi to access services. I know typically they've tried to get shelters running in some other areas, and it's not necessarily sustainable in terms of the resources it takes to provide a full-time shelter. In terms of getting folks moving toward getting them into housing, we do have, our entire state is actually falls under one COC or continuum of care. So we do have one housing management information system database that we access. So our folks that are moving around, if they sign off, it's an informed consent process. People have to agree to be entered into that process to be reviewed and referred out to housing services. We have folks across the state and locally who participate in that system. And if someone moves from, say, here to Billings or somewhere else on the eastern division of the state, they can be entered and they can still choose where they would like to settle down if that housing resource is available, so that we can get them off of the street or out of shelters, because it's, I think most of us are fairly aware, it's typically really expensive to provide emergency shelter to folks, and in a lot of cases it can be more cost effective to just get them into housing as quickly as we can. So I would suggest that the state maybe look at expanding and try to possibly look at working with the state continuum of care to find out how we can make our systems align. A lot of Montana reservations have their own housing and urban development housing programs for tribal members, and those look very, very differently across the 9 different reservations in the state.
Thank you so much, Netta. So we have just a few minutes left, and in these final minutes, I wanted to ask everyone, I know we've talked a lot about community partnerships already with public health authorities and shelters and other community partners, but are there any other partnerships that you would like to highlight that have been especially helpful to you in executing a coordinated COVID-19 response plan, such as with transportation companies or hospital systems?
So this is Netta again. I can chime in on that. We do, through the clinic and through our Healthcare for the Homeless program, have an agreement set up with a cab company so that we can issue cab vouchers online. They set up some of our wonderful social workers as essentially with dispatch, cab dispatch access to log in and authorize rides for folks, so we reimburse them at a contracted rate. Our state Medicaid program did actually approve for some expanded options, so we have some public transportation. They're kind of limited. Options for folks that live in outlying areas to ride one of the buses, and if it is for an eligible Medicaid reimbursable appointment, Medicaid will directly reimburse some of those bus companies coming in from outlying areas, because we do have lack of access for folks who are maybe uninsured, underinsured, or low income in outlying areas. So they typically have to come into a larger hub in order to do that. And a lot of folks, as I believe Melanie and Cindy both mentioned, often aren't going to come in unless it's a life or death situation if they don't have access and the money for gas. We also have folks provider agreements to transport people specifically from our quarantine and isolation site or I believe the non-congregate shelter. Oh, and one of our outreach teams has a van in which they can do some limited patient transport or individual transport for clients as needed.
Hi, this is Melanie.
Oh, go ahead.
I just want to say quickly, I know we're almost out of time. We do have transportation as well for certain programs that we offer within the continuum of care, but we have decided to not provide that transportation for people that are experiencing symptoms. And so what we are doing at this point, and what we are encouraging the homeless population to do that's unsheltered, is that if they are experiencing symptoms where they believe that it's life-threatening, to call the 911 and an ambulance will come and pick them up. And then just like Netta, we have a transportation service through a local company that does provide transportation in all of the counties. However, there is a 3-day appointment time that you have to set up the appointment 3 days in advance. So we are a little bit more limited than what Netta is as far as transportation goes. We actually don't even have taxis or Ubers in our communities. So it's just something that we are trying to navigate on a daily basis when we do find individuals that are experiencing symptoms related to COVID.
This is Cindy. I would add, as far as, partnerships and collaborations, that there have been a lot of unique collaborations created during this time. Even just, when we did street outreach on Wednesday in a very, in a rural county, there was a hotel there that was working with local boards and different groups of citizens who just had a heart to help people who were homeless. And so they'd opened their doors and they were housing people who were homeless, and found that it was a very positive experience. They had wondered if it would be a disaster, and it was very positive. And so how can we build on those relationships and maintain those relationships even after the pandemic is over? Are there hotels that are housing people now that would be willing to continue in some sort of relationship as we move forward, and to look at, even now, while these relationships are vital, what can we do to continue that and to continue those collaborations? And if there are agencies that we've never talked to before, where the shelter system and the clinic, or the shelter system and the health department, where they've never communicated before, how can we now, when we're having to talk to each other, how can we develop some way to do that moving forward, I think is really important. There have also been counties that have had to reach out to the Office of Emergency Management and organizations like that they've never talked to before. And I think there are counties where the Office of Emergency Management, has realized we don't know anyone who works with those who are homeless. And there's been this big gap there, where the American Cross has realized we don't know anyone who works with those who are homeless. And there's been a big gap there. So what can we do to build structures so that these relationships are in place, because that's going to benefit everyone in the long term.
Great. Thank you all so much. And that's a great point, Cindy, and something I think that we'll continue to look at is how we can sustain these types of partnerships and programs that have come into place with this issue, and how we can keep an eye on the future to make sure that that happens. We are right at time, so I just want to take a moment to thank everybody for attending today. Thank you so much to our presenters for all of the wonderful insight and discussion that you provided. Everyone, please note that we do have many webinars and coffee chats and COVID-19 presentations coming up soon. The registration links are there in the resources pod. Our next one is on organizational strategies for supporting the mental health and wellness of providers and staff. That will be on Tuesday. Again, the registration link is there. There is an evaluation that will come up for you as we exit out the webinar today. So any feedback or insight that you could provide to help us to keep these going and to improve our processes in the future is always welcome and appreciated. Thank you all so much. This presentation has been recorded and will be available on our website within 3 business days. And have a great day, everyone. This webinar is now closed.